This is the Owens Recovery Science Podcast, hosted by physical therapist Johnny Owens.
Hey there, welcome back to Owens Recovery Science Podcast. Man, I got to apologize. As always, it's been too long since we put a new podcast up. It's hard to find time. It feels like we're all just flying all over the place right now, and can't everyone get together. But we're going to work on that, so we'll get it out. Today is going to be a fun podcast because we're going to tackle one of the questions that we always get. I mean, man, at conferences, everyone comes up afterwards. It's the first thing they ask when you're teaching. Before you can even get to it, which we talk about more in our afternoon session. It's, can you get a proximal change with blood flow restriction? Everyone does a kind of little goofy like choking sign, like what do you put the cuff on your neck? So from a rehab clinical perspective, and even from a performance perspective, if we can get changes at the shoulder, at the hip, at the spine, which I'm not so sure about, but definitely at the shoulder and the hip, that's pretty powerful. And so there are some papers, they looked at it. Some have some flaws. Some people really debate them. But some new ones have come out with more of a clinical bend to them that might give some credence to it. So today we're going to go over that, some of the theories, and also, kind of what the literature says and how we might apply this, at least from the clinical perspective. As always, if you like this podcast, please go on to iTunes or wherever you get your pods and subscribe. And if you really like it, we love to hear good feedback. Go to info@owensrecoveryscience.com if you'd like to submit some questions. If you read it on air, we'll send you a T-shirt. We didn't get to questions today just because we, as usual, went kind of long because apparently I blabber a lot. And also, if you're interested and you're not part of our certified providers, go to owensrecoveryscience.com. We have links to courses all over the world right now. And so you can be part of our group of folks who have gone through the certification. And as part of that, it's not just that you go to a course and it's done. We really want to make sure that people do it right. And they have support because, man, this stuff changes. It feels like every week. And so we have an inner circle, which is just our certified providers where we can ask questions with each other. And we'll tackle everything from with neurologic conditions, or this person has a clot, or this person has some sort of contraindication. Particularly, we have a science advisory board that has orthopedic surgeons and cardiothoracic surgeons, tourniquet experts, BFR experts, cardiopulmonary experts that can also chime in with questions that we might not have an answer in the literature. And so that's just part of what we like to offer, along with you have access to my email, to our team's emails with any specific questions. So we really like to keep this as a family that's trying to learn how to do this the best way possible and stay up to date on it, because it's pretty cool and a pretty powerful thing. So without further ado, let's get into the podcast. All right, everyone, welcome back to Owens Recovery Science Podcast. Just kind of getting our group back together from the road warriors that we are over the last few weeks. So where's everyone been, man? I want to hear what you guys have been up to. Ben, what's up with you recently?
Well, I just got back from the frozen north, that is Michigan. Had 2 courses this last weekend up in Ann Arbor and East Lansing. The one in Ann Arbor was an open course at MedSport, which is attached to University of Michigan. It's with their medical group. Very cool facility, great people up there. And then East Lansing, for the Michigan State group, we had the private course. I had Brett Nwantney helping me out with those. He's from up in South Dakota. And I got to make the drive from East Lansing to Detroit in a nice snowstorm. So that was a lot of fun for a Texan that doesn't drive in snow to see some people losing control and drive 30 miles an hour the whole way on the highway.
Cool.
And then, right before that, I was in the Phoenix area to work with the Giants at their spring training facility to train their medical and strength conditioning staff. So very cool to be with that group over there. Already had worked with one of their physical therapists, so got the rest of the staff trained up. So fun to break those guys off a little bit and let the S&C guys go a little nuts in the lab and play around with some BFR.
I love going to the spring training, man. It's a blast out there. Kyle,
Right.
what have you been up to? Kyle?
Me?
Yeah.
Me? Oh, my bad. I didn't hear you. I lost. It's these old ears, man. I don't know. Like, I hadn't had coffee yet. And early out here in SoCal. We had a big LA course right at the beginning of the year on January.
All the LA courses are big, man.
12th, man. Yeah, they're fun. I mean, we had like 34 people there. Guys from the Padres, Angels. My buddy who runs Ignite Physio down in Orange County. So you got to follow him on Instagram because you just never know what that guy's going to do. He runs a build a booty class at a CrossFit gym, and then just yesterday he's working with a pole dancing group.
Nice.
So I message him all the time, like, what on earth? You got the most interesting people you're working with, man. So eventually we're gonna have some. Maybe we'll get him to do some BFR pole dancing videos. I don't know.
Following him on Instagram right now.
I've been saying for a while we've got the ability to do Brazilian butt lift by BFR. I mean, that's marketing scheme, right?
So he's a great, and he's a fantastic dude. Really, really sharp guy. I love too because you'll see him treating just run of the mill people. He's not one of these guys posting all these fancy high-end athletes that he treats, and those are the only people he works with. So he's out there doing the real dirty work, taking care of people that have real serious problems. So he's fun. But at any rate, we had that course here. I was in, of course, we were all at CSM a couple weeks ago, and then I did a course for Santa Clara University up in San Jose, which was a lot of fun. Some sharp folks there, and then I'm headed out Friday to New Orleans to do a private course in New Orleans, eat some crawfish and get maybe some beignets. We'll see.
Kyle, man, you pick LA, New Orleans.
Yeah, I'm staying warm. It's raining. It's raining in LA. That's basically like 10 feet of snow in the Midwest.
Driving all over Minnesota. Or Michigan.
It rained the day I had my course in Orange County, so I had I had to take chairs and rent a car. It was, it was really rough.
Yeah.
You mean when you rented the car rental place was open when you got there?
Yeah.
Oh, okay.
Yeah, it was.
Yeah, Zach, let's hear your stuff, man.
Didn't do much at CSM besides, go touristing around with Kyle to look at the monuments. That was the highlight of the trip. I mean, getting up at 5 a.m, and we had to wait until Friday, until the government was reopened so we could go see the monuments and the museums. That seemed to be, it was a little chilly. So, Kyle was fully prepped with isotoners. And he was outfitted, and so that was CSM for me. And then last week went to Chicago. I thought the polar vortex had already passed. Well, it looked like they got a pretty massive ice storm, and so I had to reroute the flight. Then 20 minutes from landing, find out that the runway is closed where I'm supposed to be. So we end up in Minneapolis. And then finally get to Milwaukee at about 3:30 in the morning. You see, Kyle, I had already rented the car, but when I got to the airport at 3:30 in the morning, the place was closed. So I had to get an Uber from Milwaukee to Chicago and got to the course about 30 minutes before it started. And then again, Kyle, Friday, Ben's traveling to Michigan. I go to Minnesota, -15 when I get there. My contact tells me, he sends me a text or an email. It says, hey, just one word of advice, dress warm. It's going to be -18 today, but don't worry, tomorrow is going to warm up. And I look at the weather for Saturday, it's still like -4. And so I'm like, I don't know what world this guy lives in.
Heat wave.
Before is warming up.
Yeah.
But coming from Atlanta, I was like, dude, this is bad. But yeah, I mean,
I sent you my isotoners.
I mean, I needed some isotoners, and then so I had another experience in Minnesota. This car that I rented in Minnesota didn't have like regular cruise control, so the drive from Minneapolis to where I needed to go was like 3 hours. And so it had radar cruise control. And so what this was it had sensors in front of the car that would determine how close that you were to the your approaching car, and then it would cut off the cruise control. Well, the sensors were froze over, and so the cruise control didn't work the whole trip.
Froze over? Is that actually a word?
Yeah.
Froze over?
Frozen, Kyle. I mean, does it matter?
Well,
I just want to know what you're saying. I don't understand.
If it's not scientific terminology, then it doesn't matter. So the thing that I've learned from this is don't ever book travel with Zach going from one place to another, because it's bound to have problems.
Yeah.
Hey, the important thing with all this is the course has went as planned. Okay.
He always makes it happen.
Yeah.
He might get that.
We make it happen. We adapt and overcome.
And so, and just to touch base on it too, CSM was a couple of weeks ago. It was great. We were all together in DC. Dr. Patterson and I did a BFR and IPC talk, and that was I think a success. We had 750 chairs in the room, and told them that probably wouldn't be enough, and they had to bring in 250 more, and they still didn't have enough, and people sitting all on the floor all over the place, and they had to put it out on a TVs in another room. So the BFR kind of enthusiasm in our profession is really taken off. So it was cool to see all of that there and get everybody together at CSM. And extremity war injuries was also that week, and so it was before CSM, which was awesome. That is a combination of AOSSM, which is the Orthopedic Sports Medicine Society, OTA, which is the Orthopedic Trauma Association, the Academy of Orthopedic Surgeons, and the Society of Military Orthopedic Surgeons all get together in DC, and we present on kind of where we are with things like BFR or other orthopedic things, regenerative medicine. And then we have steering committees where we all get together after our talks and decide, this is kind of the direction we think things should go, and maybe see if we can get funding pushed for certain studies. And so that was awesome. The impactfulness of that with big decision makers, and then the enthusiasm of everyone at CSM was a blast. And then, of course, lots of after CSM partying and drinking, and the real action happens at 2 a.m. with bourbon in the bar, where the decisions really are made. So that was awesome. And then we got stuff coming up. Ben, you're at Andrews Institute, this weekend? Is that right?
Yeah, so I'll go to Plano this weekend and have the Andrews Children's Health. And then the next weekend I'm going up to the Chicagoland area. So hopefully the winter weather will cooperate.
So if anyone's listening, the one this weekend in Dallas, I don't think it's sold out yet. So if you're interested in get certified in BFR and get into this, you still got time. The one in Chicago is full. It's sold out, I think.
Yep.
Yeah. And then we have one coming up in Georgia, right? This month.
Yeah. Yeah. So that's next weekend. It's an open course in Marietta, just outside of Atlanta. And then I'm headed to Detroit this weekend coming up. So to talk with a hospital system up there. So.
Nice. So this month, if you're in Atlanta or you're in the Dallas area, there's still time, still some room. And also, we can't forget our folks doing this with us worldwide. So we just did the Jordanian military last weekend. Those guys love it, and we've been working with them a whole lot. And up in Canada, we've had some courses. We're about to have one in Barcelona with our friends down there that are going to start training throughout that region. And then we also just had one in London not too long ago and got Arsenal trained up, which is cool. So we're starting to get those Premier League teams coming on board. Cool. All right, you guys ready to get into this proximal big bear of a question?
Yeah, I want to make sure we don't miss something on the whole CSM where, we had a guest appearance at the booth by a researcher named Luke Hughes from over in the UK. Oh, yeah. Mr. Weak Sauce himself.
Yeah.
Was able to come and talk some BFR with us for a little bit.
All he did was walk around carrying his research paper.
He kept showing people that systematic review. Every
I think he posed. Yep. Yeah. He posed for a picture. With some folks that recognized his study and couldn't believe it was actually him.
Really?
I think he was trying to pay people to take his autograph.
Well, he is Dr. Hughes. He became Dr. Hughes right before he traveled. Right. And anytime I walked by, I just saw him trying to talk to the cute girls.
Right.
So
exactly.
Yeah, so I think I saw where his motives were. All right, man, let's get into Proximal. All right, fellas. It's been a long time since we've got together for a podcast. We've been together a lot and all over the place, but dang, man, finding time to schedule this stuff when everyone's on an airplane somewhere has been tough. So welcome back, everyone. We got the crew back here to get into some really deep and potentially contentious discussions today on Proximal. So we got Ben Weatherford here with me in San Antonio. Dunkel is going by Smashing Frickin' Wade on his moniker on our GoToMeeting here. And Kyle is tardy, not tardy. The light is shining off the top of my head where he is out there in California. So welcome, guys. And so we're going to talk about Proximal. What happens above the cuff or in another part of the body? Whenever you're teaching this stuff or presenting at conferences, it is always like one of the first questions people have is, okay, what about above the cuff? How can I get the shoulder? How can I get the hip? You know, people make the joke of, do you put it around your neck or whatever? And so there's a lot of kind of back and forth from physiologists of what they think happens or doesn't happen. And some of it might just be getting too mechanistic and just saying, well, let's just measure the changes and see that it happens and maybe not fight over why it's happening. But everyone wants to know why. So we're going to get into this today. So I think let's discuss kind of the older papers first. So like Yasuda was one of the first people who started kind of tracking this with some bench press studies. And so first off, everyone is on this. It's systemic, and everyone jumps on things like growth hormone, or you're driving muscle protein synthesis mTOR. You've got all this anabolic drive, and so it's got to be systemic. And from the physiological standpoint, that may not be a real driver of growth in other regions. And so what Yasuda had is, low load bench press or low load bench press with a tourniquet on. If you measure muscle activation on a proximal muscle, which was the pec, EMG activity went up. And so that isn't systemic. If you're just seeing an increased drive in EMG, then something is making that muscle work harder. And so the first theory that people kind of go to when you look at that is a downstream fatigue. Can I fatigue the triceps when I'm doing bench press because I got a cuff on, and you can make the downstream muscles get so fatigued that the proximal muscles have to work harder, right? And so I guess from y'all's standpoint, what do y'all think on the downstream fatigue theory? Do you think it's something that is like, that is our main one we got to look at, and that's an easy one to go after? If I'm going after the hip, let's downstream fatigue the quad, and the glute has to work harder in like a multi-joint exercise. What's your thoughts on downstream fatigue?
I mean, for me personally, the one thing I get from that is, and we can see the same thing in other studies where it might show a remote effect, is no matter what, if we're trying to have an effect on a muscle group that's proximal to the placement of the cuff, it needs to be involved in the stress that we're creating with the exercise. So if it is, like the Yasuda study or the Abe 2-week, squat and hamstring curl study, the muscles that we're trying to target with the hypertrophy have to be significantly stressed with the movement that we're putting on and the exercise involved in the application.
Right.
Yeah, I completely agree. And I think, the data, it has to be somewhere around in that 20% of MBC mark. And where I pull from that from is we see these proximal changes in the bench press and with the pec, and then we see it also with squats, with the glutes. But then you take an exercise with walking, we don't see any change into the glute. And right. I think the big driver of that is because the glutes aren't really active, during low level walking.
Yeah.
So the muscle group that we're targeting has to have a certain amount of activation, and simply putting the cuff on a limb and doing an exercise isn't going to make a non-active muscle active.
Right. And I think that's this key. And Jeremy and Dr. Abe in that ACSM paper that we put out, we talked about the proximal muscles. From what we've seen, they're probably going to have to be involved with at least a 20 to 30% type 1RM. And so that's the big problem if we're talking clinical here, because everyone's like, hey, I want to go glute on this FAI who just had this labral repair, or I got a rotator cuff. That ain't going to happen, right? And so if we're saying a downstream fatigue effect, then you're probably talking later phase clinically, where you can put some load on that squat and really fatigue out the quad, but also get activation of the glute to really start to see some changes, right? And
Yeah.
And I guess so. We got to talk about the other paper. So Abe's paper, break it down. It was what? It was 2 weeks, high frequency, right?
Yeah, 6 days a week, training twice a day for 2 weeks, squat, and then leg curls.
Right, at 20%, right, or 30%? It was at 20%. And so that's some things that we have to point out as well. You look at these papers in the literature, you're like, damn, that's a nice change. But that's 6 days a week, twice a day, at 20% load. And those of us who've actually done it or have patients do it, or anyone else at 20 or 30% 1RM, it's a beast. It's tough.
Yeah, squats at that are pretty challenging.
Yeah. And then what was Abe's results on that?
Yeah, so hypertrophy standpoint, quads hypertrophied 7.7%, glutes were 9.1, and then the hamstrings were 10.
Right.
So I really think that the hamstrings, the reason why we see the greatest change in the hamstring was from the leg curl.
Yeah.
Typically hamstrings aren't going to be overly active with a squat. So
yeah, it's interesting. They just kind of threw a leg curl in there as well.
That was odd,
but still almost 10% change in the glute on their re-imaging from doing that. And strength change as well. So they were stronger on their 1RMs, right, on squat and hamstring curl.
Correct.
Right.
Yeah.
Right. And so then I guess, if we're talking this downstream fatigue thing, the big question becomes, okay, how do if I am going to be able to put some load on, how do I target something like the rotator cuff? What are you downstream and fatiguing when you're doing like an external rotation? There's not a downstream external rotation muscle. What do you guys think when you've done this or seen it with patients, or is there a potential that something's fatiguing out, making the cuff work harder?
I think there does seem to be something happening because we do see folks having more fatigue when they're adding the cuff versus not. The one theory that kind of gets floated out there is that sort of that backflow effect. I think when I talk about it, I talk about like maybe there's this retrograde kind of restriction. I make an analogy with like if you're pouring water in a funnel, at some point, that water starts backing up that funnel, and if you've got a cuff on a proximal limb, potentially that's what's going on. I mean, I think we kind of chatted about this before. There's literally like nothing out there that's demonstrated that's actually what's happening. So it's important to kind of keep it in context. But
such an easy study to pull off.
Yeah.
Getting
somebody to do that
and measure blood above and below, and it seems like we should be able to pull that off. Yeah, because Dr. Elatrosh last year when we were together at that little mini conference, he's like, I love it on my shoulders. I'm seeing changes. The patients are like, it feels like it's definitely just after one bout different and better. And he's like, it's backflow. I know it's got to be backflow. And it's, and so for him, that was like his theory. When he says, I talk to people about it, I just tell him, I think we're really backing the blood up where you're just not getting enough into that proximal muscle because we've clogged the plumbing up downstream. So,
right.
Yeah, that group in particular has really been excited about what they've seen from their shoulders. Folks that are doing BFR versus groups that are not. So,
there's.
Say again.
What'd you say? I didn't hear what
I said. That group in particular, the Curl and Job group, has been pretty interested in what they've been seeing from their groups that are doing BFR with shoulders specifically versus their PT groups that are not doing BFR. So
Yeah. Well, I was with Dr. Robin West, who's the Nationals team doc yesterday and the Redskins doc. And same thing. She's just like, and she's had a shoulder problem and has done it. And she's like, man, there's something really happening at the shoulder. And I love it with our baseball people and our patients as well. So everyone's seeing something. And you can tell, man, if you do like scaption with one arm with the cuff on and one arm without, I mean, it's night and day. You ask anyone, it's like, wow, my shoulder is definitely working way harder on this side with the cuff on.
Right.
But you feel it in the cuff. You feel it in the shoulder musculature itself.
Right. I mean, I think initially for me, I thought it was just, potentially a function of we're doing a high volume of reps with pretty short rest periods. Maybe it's just that we're doing, this significant exercise that's probably more stress and reps than what we were doing before. But doing your own work match control, it feels very different. I mean, the recovery is different. There seems to be more of that metabolite response and more fatigue on the limb that has a cuff versus one that doesn't. I mean, I think it's like the Bowman study that just came out and showing a difference with, the hip doing some side-lying abduction. I mean, there's not a downstream fatigue happening there.
Exactly.
We don't have this big accessory movement that's, we're getting a lot of help distal to the cuff. It's, there has to be something different about it.
Yeah, we'll talk about Eric's study in a minute, as well as Bradley's shoulder study that he's done. So, okay, then you move into it's systemic. There's got to be this systemic effect going on. It's so kind of break down, everyone, what your thoughts are on, is this a systemic thing? And should people, we had a guy we all know saying, well, I just put it on the arm and have them do all their lower extremity rehab with it on the arm for like 30 minutes, keeping it on the whole time. It's like, I'm not sure, man. But what do you guys think from the systemic standpoint? What do you think are the drivers if it's saying systemic?
Yeah, so I think from that standpoint, one, I think you're going to get a much better effect if you occlude in the lower extremity versus the upper extremity. I think it's a blood flow. I think it's an amount of blood flow, and that's going to drive a hypoxic response that contributes. From that standpoint, one of the Abe, the squat paper, what they specifically looked at was the change in IGF levels and more of resting IGF levels, not an acute following the workout bout. So they trained for 12 days, and then they did the lab draw on day 14. And what we see is about a 23% increase in IGF levels. Mm-hmm. We think IGF plays a role not just in muscle protein synthesis, but actually contributing to the proliferation, differentiation, and ultimately the fusion of satellite cells.
Yep.
And so what we get out of, say, 6 months of moderate to high intensity resistance training with both males and females is about a 19% increase in IGF levels. And so what we see is this resting levels of IGF are a little bit higher with the cuff on. So maybe that helps to explain some a systemic change that we see.
Yeah. So, so Matarame's study, let's discuss that one, because that was kind of the first one, got people kind of worked up at ACSM years ago. So one arm, they call it light curl, but what is 50% 1RM, right? It was,
they trained 50% of 1RM.
Yeah, so that's not really light, but lightish. And then the other arm, they did nothing. And then they finished it by doing squats with or without cuffs on, and depending on which group you're randomized to. And it was 20% 1RM squats. And then what they wanted to see is, was there a change in the upper extremity that didn't have a cuff on at all? And they found a change. So the arm that didn't do anything, there was no change. So there's no free ride, no free lunch. You're going to have to probably do something to get an effect. But the arm that did do the curls in the BFR group got bigger, and it got stronger in the bicep, and they were doing bicep curls, right?
Yeah.
So that got everyone like, bullshit, you're full of it. And that was this, okay, it's all systemic. They measured kind of things that maybe weren't that big of a deal. They measure like noradrenaline,
growth hormone,
and that if you're going to put your hat on, like, these are the drivers of this proximal or systemic effect, those probably aren't the real ones. And that might be why people also got worked up about it. But it happened, right? And so then Warmington's group over in Australia, I think, kind of to disprove that study or just to validate it, repeated it. pretty much same design, and found that the arm again got stronger in the cuff group. They didn't reach significance for hypertrophy. I don't remember what their values were, but it looked like it was kind of trending that way. But then this other paper came out and kind of confirmed it, right?
Yeah, the other thing with that Wormington paper was they trained for 2 weeks less as well.
Mm-hmm.
So they trained for 8 weeks versus the Mataram study trained 10 weeks.
Right.
So, maybe, the additional training sessions over those 2 weeks, I don't know, but.
Right.
Well, and they did 2 exercises on the legs instead of just one. Also, they did the knee extension and the hamstring curl instead of doing a multi-joint and the squat.
Right. And so if you're saying, I want to get this big systemic type thing, a multi-joint is probably where you're going to go, right?
Right. And it was interesting. I mean, they did a 60% pressure, which we know, from the limited research out there on the differences in pressure and what happens at 60%, probably creates some stimulus, but maybe not as big of a stimulus as what we would get at something like an 80% pressure.
So what do y'all think? What do you think's the systemic target pathway? Is it IGF? Is it satellite cells? Is it just freaking hypoxia?
Yeah, all of the above.
All of the above.
I mean, it seems like
right. We try and break it down into individual things, and it's always all of the above.
Yeah, because all these things happen in isolation, so we can target one and say that we're getting this significant change. And I think that's the thing is we really don't have. Any.
That was Ben's sarcastic voice right there. That was all.
Yeah, if
sarcasm.
anyone didn't catch that,
in case you didn't catch that was sarcasm.
Isolated.
Well,
it was all in isolation.
Why don't you guys test everything?
Yeah, I'm gonna hang my hat on one thing creating the big change for us. And I mean, to me, it's I think there's obviously it seems like there's a lot to be had potentially with this hormonal or systemic response. It really looks like you can't say there's not a systemic change, and there's an elevation of hormones typically associated with that. So is that truly a direct correlation? We don't know. Obviously, if you can do something to upregulate and incorporate satellite cells, it looks like that's probably the huge win for us. Whether that's hormonally driven or not, looks like it might be, but we really still don't know. No matter what, it looks like there needs to be significant stress in the area. Looking at the Cook rugby player study, it's putting it on the legs, even doing the squat, same exercises in both groups, squats, bench press, and pull-ups. The group that had cuffs on the legs for the exercise had a significant increase in their 1 rep max in squat, or 1 rep max on bench press, I should say. So, I mean, I don't really know that we can say that we know what's driving it, but it looks like there's a lot of systemic potential. Just have to have significant stress. And then the whole, passive cuff application, I think, we probably need a significant amount of hypoxia on a non-exercising limb to have a remote effect. And to me, with all the literature there on putting the cuff on the exercising limb, I feel like that's always the better target if we're going to be applying exercise within session.
Right.
Yeah. Yeah, I think I completely agree. I mean, I think you got to, if you're going to try and target a limb that you're not occluding for whatever reason, you have to train that limb. I don't think we're going to get this carryover into a non-exercising limb if we're trying to do anything remotely. And just like Ben said, I do think that there's a hypoxia aspect to that. Whether that, and what triggers or what does hypoxia do, whether it's, the contributor to VEGF. I think that may be a potential, but yeah.
Yeah. And so I touched on this a little bit right before our call too. At Extremity War Injuries a couple of weeks ago in DC, we had a regenerative medicine session, and Josh Winke got up, who's kind of our regen expert down here at our base. And he said, no matter what we're doing, if we're targeting quality muscle changes, you have to start looking at either pharmacological targets that we can come up with or things like BFR that drive the satellite cell pool. And so the satellite cell, you can call it the muscle stem cell or whatever, is the key to all good things for long-term muscle repair and muscle growth. And so you were mentioning, Zach, that hypoxia might even replenish that pool from what you've seen.
Yeah. There's a paper out there that looked at basically when we create hypoxia, it'll actually replenish the satellite cell pool, and that's one of the important things, because we talk about in the course about this ability to proliferate stem cells or these muscle stem cells. Well, the problem with that is if all we're doing is replenishing stem cells, we're going to drain the stem cell pool.
Yep.
So we have to, so it's great to do that because we think that, ultimately some of these we're going to fuse to the fiber. But the problem is if we don't replenish that pool, we start to deteriorate the pool. And that's a problem that we see with these ACLs.
Right.
So we see this decrease in stem cell or satellite cell pool. So hypoxia may be a driver that we can actually boost the satellite cell content, which is what Nielsen showed in their paper. So we see, in 8 training days of high volume training, but, after the 8th day of training, we have this about a 290% increase in the satellite cell pool. So that's huge. And so the question, ultimately is, well, what drives that increase in the satellite cell pool?
Mm-hmm. Yeah, and before we get any further on this, I can sense Kyle getting bent out of shape because I remember from our discussion last night, we need to make sure that we differentiate between the satellite cell response and the myonuclear accretion or the addition of myonuclei to the fiber, which is really what we're getting after, because the proliferation looks important because that's how we have more to incorporate, but the incorporation probably being even more important to say that we've got more places for protein synthesis to happen over time.
Yeah, agree with all that. I was going to back up to Zach where you're going with the hypoxia. I suspect that the theory ultimately is these satellite cells live kind of close to these capillary beds. This is ultimately some sort of a hormetic response. We induce this hypoxia.
Well, and Josh corrected me on that. We had a meeting later on, and Josh corrected me that there isn't really more of an abundance near the capillary beds from what he knows. And so we were told differently and have seen differently, but he said it's basically throughout the muscle, and it just lives quiescently just right outside the fibers, and there's not a difference at the capillary beds, although we've been told by other people differently.
Yeah, and I think maybe this is where the confusion comes in. What we see in both young and old is the satellite cells that become most active and start to proliferate and differentiate are closest to the capillary bed. I think that may be the confusion piece with that. So we see that both in the elderly and in young, and that may be one of the drivers of why we can actually see such the great changes we do with the elderly folks, is because the increase in VEGF that leads to a greater change in capillary density. Then maybe we have a greater ability to activate muscle stem cells.
Right. And it probably has to be some pretty good hypoxia and maintained hypoxia as well. Like the Nielsen paper, they're using Zimmer, basically the Delphi, the ones we use, these surgical cuffs that maintain pressure, hold a strong, deep pressure. These pump up ones, they drift. So you're going to start with pressure and then it's going to drop down. So because that's kind of in our next thing with like remote ischemic preconditioning, they're basically getting into full hypoxia and having sparing of cardiac muscle, just by putting it on a limb. And so it's this deep hypoxia, potentially this driver of change, either less damage, less breakdown, or more drive of something like myogenic stem cell incorporated into the fiber. Agree?
Yeah, absolutely.
I don't know. Kyle's shaking his head again, man.
No, I agree. Yeah, that all sounds good to me.
Well, and then so based on what
I think Zach makes an interesting point about, perhaps it's, those satellite cells sitting next to those capillary beds, those are the ones that are potentially moving around and responding to the stimuli. That is an interesting point. And who knows? It'd be interesting to talk to, was it Josh you said, Johnny, that so that'd be interesting to maybe pose that question to him, see what he thinks.
Well, and here's really where we found out that you have to have this abundant satellite cell pool for muscle to ever changes when we're trying to regrow it. So when we put an extracellular matrix into lost muscle tissue, there wasn't a satellite cell pool. And so what happens is you lose a chunk of muscle, you lose this large amount of satellite cell. And matrix, which has some sort of stimulus to make things regrow, would make fibrosis grow, and it wasn't making muscle grow. So now we can take muscle from elsewhere and basically grind it up, and it's just full of a ton of satellite cells. And then you shove that into the lost muscle and replenish the pool. And so basically what Josh said is we just have to replenish the pool to be able to make the muscle respond again, because the satellite cells were key. And that's where you do this combination with blood flow restriction. So you keep proliferating more and more satellite cells from outside where that defect was. But it's like the case in prehab paper. This loss of angiogenesis was a driver of atrophy, it looks like, the first 4 weeks, right?
Yeah, the preconditioning, not conditioning paper.
Yeah, right. Exactly. Don't know why.
That paper is fascinating, though.
It is, so maybe there's an ischemic reperfusion injury from surgery. You have less capillary beds in the thigh, and you lose muscle endurance, and you see this atrophy happens. And then you precondition for just a few rounds. What was it, like 5 sessions or something pre-surgery?
5 sessions over 8 days, I think. It was.
Yeah, so basically they say preconditioning. It was really just BFR exercise. Again, at pretty high hypoxic level, surgical tourniquet on there, Delphi, and they saw angiogenesis come back quicker in that group after surgery and less atrophy at 4 weeks. So the muscle was preserved from an endurance standpoint or from an atrophy standpoint because of the increase in angiogenesis. Now, at 12 weeks, both groups were equal, but they didn't do any BFR post-surgical, So I think, because someone pointed out, well, at 12 weeks, they were both equal. But it's like, well, yeah, but I don't think I would have my people just do 5 BFR sessions pre-op and then say, okay, now just go back to standard of care. I think we would have driven a lot more action and seen changes in 12 weeks.
And you have those Ashish Bedi papers showing that you've got to really kind of fight these, TGF beta pathways post-operatively as well. So if you set them up to win pre-operatively and then you take it away post-operatively, you're going to have a hard time getting people to enlist in that study at some point, right?
Yeah, for sure. So then the question clinically, based on if we're talking this systemic from Warmingtons and Matarames, is if I got a rotator cuff repair and I can't really do anything to it, then you potentially could do your light rotator cuff exercises and then throw them on a multi-joint type exercise like a leg press or something like that under BFR afterwards to kind of repeat what those studies said. What do you guys think of that clinical approach?
I love the idea. I think, a lot of people struggle with it because, good luck billing for your time on lower extremity exercise when you've got an upper extremity pathology in the clinic. But, physiologically, it makes a lot of sense to me. We always talk about the old bodybuilder principle of do heavy squats if you want big biceps, and it seems to be some validity there.
Yeah. What do you guys think from a clinical standpoint? Is that something you guys do at all, Zach and Kyle, or?
I usually try to coach my people up to go train heavy in the gym, honestly. If I've got somebody that, you just never know. It's always patient dependent. But if I've got somebody that will get in there in the gym and work hard, I just make sure they're doing that on their lower extremities. I haven't, I don't want to say I haven't, but it's been uncommon for me to really kind of go after, that systemic response because it's hard to fit into a clinical day. If I had an hour and a half with each patient, and carte blanche, then hell yeah, we're getting after it. That's why I say, man, if my friend gets hurt, they're going to do great, but the constraints of the current system also kind of limit what you have to do. So, so often, for example, with the shoulder, man, crap, you're just trying to get the range of motion out of that thing, because they're painful. It's just a challenge there to even get to the point where you could even think about asking them to do 75 repetitions of something.
Yeah.
So that there's a number of barriers, I think in the clinic to applying some of this stuff. I think it's important that we have a good foundation in our reasoning so that we're able to apply it when we are presented with those opportunities. But man, there's a lot of limitations to applying some of these things in reality.
What do you think, Zach?
Yeah, I tend to agree with Kyle. Sometimes I'll definitely try to, if it's an upper extremity issue, and try to basically do something that incorporates the lower extremity. But in other cases, man, we've had some of the patient populations that we work with are CrossFitters, Olympic lifters, things like that. So if it is like, I mean, we've had CrossFitters with shoulder surgeries that are that go back to CrossFit, shortly after surgery and start doing like heavy sled drags and things like that. Basically where you can take the upper extremity completely out of it, but still work the legs.
Yeah. And so it is, if you have carte blanche, you have all the time in the world, you're one of these pro teams, college teams, or clinically you can just do it, then it's probably, from what we've seen in the literature, makes sense if they're already starting some like light rotator cuff strengthening exercises. Then go ahead and have them do a finisher, throw the cuffs on their legs and go do leg press or something like that. If you can do it, you get away from the risk of I'm running with a sled and I've got my arm in a sling, bouncing it around and all of that. Or, if you're looking at Grandma Smith, who really you would love for her to get in the gym and do this stuff, but she's probably not. Then this might be a nice kind of extra adjunct. And you're making Grandma Smith's legs stronger. which right. Didn't hurt either. But that is a problem that, how to apply that clinically. That rotator cuff trial that we're hoping to get going up there in Minnesota, we'll maybe have some clinical data, but let's talk about Bradley's paper now that's not published, but it was just presented at Extremity War Injuries. He's down at Methodist Houston. He's kind of the head of the orthopedic research down there. He did more of what we do in the clinic. So these rotator cuff exercises in professional athletes, baseball players. So have you guys been able to look over that?
Yeah.
So
the poster.
Yeah, it was 2 times a week for 8 weeks?
Twice a week for 8 weeks, yep.
And rotator cuff exercises. So what was it? It was cable column external rotation, cable column internal rotation, sideline external rotation, and scaption. So 4 exercises. Those are very rehab specific and easy to pull off. And 2 times a week is kind of in our rehab wheelhouse here. These are well-trained individuals who are already strong. So we're talking healthies. This isn't clinical, unfortunately. But what Bradley found from that was that the muscle endurance was significantly better if you were in the BFR group. So one group did it with cuffs on, the other group did it without cuffs. And this is pilot, so the small numbers here. I forgot what. Do you guys remember what he had? I think it was I
think it's 15 or something.
Something like that.
Yeah.
The muscle endurance, especially with the external rotators, was significantly better. Muscle size, so lean muscle mass was significantly better in the rotator cuff, and that was on DEXA. And then he also found that muscle activation was up significantly higher in the BFR group as well. And so, what are you guys' thoughts when you first saw Bradley's poster presented, and would that change the way that you look at doing proximal stuff at all?
It did me. It did me. For sure.
The results are great. You look at from the strength standpoint, again, I think it really goes to kind of the specificity of it all. When we talk about like muscle groups being active, if you look, the external rotation at 0 degrees compared to external rotation at 90. So at 0 degrees, we think predominantly infraspinatus, not maybe getting a lot of teres, but we have a significant increase in the BFR group compared to the at 90 or at 0 degrees in the control group that just didn't do BFR. So again, I mean, I think if we're going to do something proximal, this kind of does establish the importance of the muscle group has to be active.
Right.
And we just can't put a cuff on and make the muscle group active.
Right. And so just to put the details out too, he used 50% limb occlusion pressure in the upper extremity, which is what we kind of philosophize and teach. So he also did a little bit differently the way he did his sets and reps. So it's a Delphi system. So we know he's getting, the constant occlusion But he did 30, 15, 15, and then the last set to failure,
Right.
which he said, to him seemed like to kind of really push that muscle activation, and that he kind of wants to skin the BFR sets and rep cat that way in his next.
I really like that. I do that a lot in clinic.
Yeah.
That last set, you can tell like get a little more in the tank. Keep going.
Yeah.
Give me 10 more, give me 5 more, whatever. Yeah.
Yeah.
Yeah, I think that definitely that helps in some of those exercises where it's difficult to establish a 1RM and to get the percentage to. Because, I mean, the whole goal in what we do, ideally, that third set of 15 is to failure.
Yeah.
And if they don't get that, then push on until we get there.
Yeah. And you have to watch your numbers there. So if they're in the third set and they're at like rep number 40, your load was way off. So that failure one can help you figure, you can say, I want you to fail at around 15. And if they're like 16, 17, and they're still going, you're like, I better get a little bit more load on this because I really missed the target.
Yeah. And then in, like I said, in the cases where it's hard to kind of get a 1RM, like I always jokingly say, someone comes into the clinic, we're going to do straight leg raises. No one's going to come in and say, hey, Zach, my straight leg raise is 23 pounds. So it's always just an estimate initially. And then you take that into a post-op situation as well. And it's always kind of a little bit of an estimate early on. And then once you kind of get things dialed in, ideally we do get to that failure in the third set of 15 or close to 15.
Yep.
Right. I thought it was really interesting in the study that percent change in lean mass. I mean, doing these, single joint movements for the exercises. I don't think of those as typically driving a whole lot of hypertrophy change in general, even with a little bit more loading, which it's hard to get more loading on those exercises anyway. But that seemed pretty significant from the poster. I mean, that's a pretty big change in on DEXA for those exercises.
Yeah, for sure. And the EMG, it peaked much quicker earlier with the BFR group, and overall, the peak was relatively higher compared to the control. So again, the BFR side, where we're getting this muscle activation, which is really what we want to target in a proximal muscle. So not in a clinical model, but a clinical type study with very well-trained athletes showing these significant changes in rotator cuff strength, rotator cuff size, and rotator cuff muscle activation and endurance. So now it's like, man, that's the easiest way to do it. So everyone's like, how do I get a proximal shoulder? Well, it looks like 2 times a week for 8 weeks doing these exercises is pretty right on target, in a healthy, it's going to get there.
Right. Yeah. Well, and not to take us down another rabbit hole on this podcast, but one of the things from that poster that looked interesting that I know, we had talked about a little bit was the changes in strength look, especially for internal rotation on the dominant arm, are more significant than anywhere else.
Yeah.
And to have the biggest, strength adaptation coming in the dominant arm that's the best trained going in was interesting to me. I mean, I would have thought it would be on the non-dominant arm because there's more room for improvement.
Yeah.
Which is,
I can't figure that out. I
can't either. I mean, that's a really interesting response.
Yeah. And it was significant. So it wasn't just like it looks like it. It was the dominant was significantly better than the non-dominant.
And more so than any other muscle group.
Yeah.
Right.
For sure.
Yeah, I mean, you're talking upwards of probably 23% on the internal rotators. I mean, it was huge.
Well, whose attention it got was MLB.
Yeah.
So Brad, good on Brad, man. He got an MLB grant to study this at spring training right now because if we can make the dominant arm that much stronger, and we can get muscle endurance, because that's what. So when we first were talking with MLB about this stuff, it's like, it'd be great if we see pitching velocities go up. But then, it's really what it's come around to is it'd be great if we see pitching velocity not go down throughout the innings. And so this whole muscle endurance was kind of Brad's main target he wanted to go after. And so we'll see, man, if these guys are able to keep that arm where their pitching speeds are going to be tracking that, their pitching speeds not go down.
Yeah, the other interesting thing is with that, the endurance and the external rotators is, do we have like maybe an attenuation of injuries in these pitchers?
Right.
Well, I mean, because we're talking, that was upwards of probably close to 47% increase in external rotation endurance.
Yeah.
Which is going to be huge.
Yeah, I think the hard thing about baseball, because you're getting into my world a little bit here, is, those velocities start going up. The shoulder, we're a little bit less worried about the shoulder at some point and kind of more worried about the elbow. The elbow seems to be what's really breaking down more and more and more. I mean, you see guys go out on the DL, but in at least in the pitching population, you don't really see them go out nearly as often for the shoulder, I don't feel like, as you do for the elbow.
Right.
And so it's interesting to see those changes above, but I feel like, man, the change in their endurance and reducing injuries, and you get into a whole different world of so many variables and things that people are doing differently in terms of baseball training now than they even were like 5-6 years ago. So.
For sure. But if they are able to increase their cuff size or cuff strength, endurance, activation, yada, yada, is that going to decrease that eccentric load? Because the shoulder's just able to handle it more, and you're not stressing the elbow maybe quite as much, Because I don't know if there's going to be a change in increase in velocity, but it's decrease in velocity. And I think that was kind of what Brad was at first. It was like, let's look at this clinically. Is this a way to reduce injury? And it seems like MLB was more like, well, let's look at this from a performance standpoint. But we hope that they're able to track. It's going to be with a couple of teams. Are there reduced injury rates throughout the season in the BFR cohort that was doing this during the spring ball? So we'll hopefully have that data to be able to look at. Cool. Okay, so that's easy, man. If I got a shoulder, just do kind of what I know we all do, is we get the cuff on the shoulder. There's another shoulder study that's registered with our guys down at Andrews with slap lesions. So between Brad's work, hopefully our cuff study comes out, and then the slap study, we'll at least get some proximal answers here in the next few years, or with the way research goes, the next 10 years. Okay, but then let's move into to Eric's study. So this was Dr. Bowman, who was at KJ, Curlin Job out there, and now he's over at Vanderbilt, sports doc, with Heather Milligan, who's a good friend of ours, and Greg Jew, the folks over at KJ Select. And so they did, again, more of, let's see what the rehab-y type exercises are like in a healthy population. So can you go through and not do, the problem is these academic studies, it's like, okay, I'm going to do this 30% 1RM squat, and we're going to do it 2 times a day for 7 days a week, and yada, yada. And it's like, man, they'll never be able to do that clinically. That's great from maybe a mechanistic standpoint, but man, tell you the truth, I'm just having to reread this. But can you guys break down exactly what exercises they did? Do you have it in front?
They did straight leg raise, sideline abduction, leg extension, and leg curl. I like that they didn't do a squat, because now we can at least, if something's happened above the hip, it's not confounded by some multi-joint movement.
Exactly.
They did isokinetic testing for knee extensors, and knee flexors, and then handheld dynamometry for hip abduction, hip extension, plantar flexion, and then circumference measurements of the thigh and leg, and they did single leg heel raises. Yeah, just in terms of their baseline and final measurements there.
Yeah, endurance of the plantar flexors.
Yeah. Again, I'm kind of working through it as we're looking at it here, but the one thing I thought, as far as the isokinetics, they really kind of went at a high speed with those, and I really feel like they were at 180, 270, 300. I feel like I see most people kind of using more that 60 degree per second metric, at least in the knee extensor world. In the ACL world, but it wasn't really wasn't necessarily the focus of their study, but it just kind of picking apart what numbers they use.
Yeah, and that's always a problem when you have these isokinetic studies, is like, it's fine to go high speed if your coefficient of variance is okay, but no one ever puts that in the study findings. Like, we did 270 degrees a second, but our CVs were like 30%. So it's much easier to control those coefficient of variance at the slow speeds, especially in a healthy individual. But the high speeds are fine. And we get some other interesting kind of things like that, like this. I think the total work numbers are kind of better and things like that. But yeah, it would be always nice to see like were their CVs within line during those tests. But anyways, going into again their exercises, those are all like post-op kind of mat exercises, pretty much. So this is something that anyone could maybe do. If they rolled into your clinic and I'd had a knee surgery, I'm doing my leg raises, I'm doing my hip abduction, may or may not do something like a long arc quad, and I could, do like a hamstring curl. So very rehab, boring ass exercises that an injured person would do. Do you guys remember what was it? 2 times a week? 3 times?
Yeah, 2 by 6.
2 by 6, 2 times a week for 6 weeks. Again, like Bradley's, very easy for us to say this is kind of following a clinical model that I can get a patient in hopefully 2 times a week for about 6 weeks post-operatively. And so let's go through what they found here. So they did CSA. What do we have for? So it was tape measurements. So take it for what it is. And people poo-poo stuff like this, but it's like, man, it's not a funded trial. This is just a pilot for concept, and there is a validity if intra-rater is good with that, as long as the same person's redoing it each time. So what do we get on that? Do you guys have numbers?
Yeah. So the percent increase in thigh circumference on the BFR limb was 3.5%. And then that's for the thigh. Lower leg was 2.8. And then what we actually saw was on the non-BFR limb was a 2.3% increase in the thigh circumference and a 1.2% increase in the leg. You compare that now with what they got out of the control group was a 0.8% increase in the thigh and then a 0.4% increase in the lower leg. So what we see is we actually see significantly greater improvements in the thigh on the side in the BFR group that did not have the cuff on.
Right.
So that was a pretty cool finding from that study again. And, so I think, again, it goes back to what we really started the podcast with was as long as we train a limb and we put a cuff on another limb, but don't have the cuff on the limb that maybe we need to target for whatever reason,
right,
we can see these changes.
Effect, yeah.
Yeah.
Well, I think that's one of the most commonly asked questions in the course is what about a cross transfer? I mean, can we use it on another extremity? Talking about post-op hips or really anyone, we're worried about getting it on the limb that has the incision. Yeah. Whether it's placement of the cuff or just the physician doesn't feel comfortable or the clinician doesn't feel comfortable.
Exactly.
Can I use the uninvolved side and create a stimulus that helps with what's happening on the affected side? And obviously we don't have great answers there, but it looks like we can potentially get some of that there.
Yeah, and let's re-explain this too. So they did those exercises on both legs.
Correct.
But the BFR group, they only had the cuff on one leg. They kept it on that leg throughout the duration of the study.
Correct.
Right. And it was they had the subjects choose the leg, so it wasn't necessarily dominant, non-dominant. Yeah. It was just preference.
And also to get into specifics, 80% limb occlusion pressure, surgical Delphi BFR system, and they 30, 15, 15, 15. So kind of the standard protocol that most folks use. And so strength then, what do we got on strength for BFR versus the non-BFR group?
Yeah, so strength increased significantly in peak torque, power in both knee extensors, and then total work in the knee flexors. And then when
total work for the knee extensors as well.
Yes, right. And then hip abduction isometric strength increased significantly in the BFR group compared to the control group. And then hip extension plantar flexor strength did as well, as did the percent increase in single leg heel raises.
Yeah. So that change in single leg heel raises was pretty impressive as well.
Yeah, 4% compared to 28%.
Yeah.
That was huge.
And really no calf exercise. Right.
And so that was, with the plantar flexion change as well as the hip extension change, I mean, there was significant response without a direct training stimulus for those movements.
Right.
Which is interesting.
Scratch your head a little bit, but
yeah.
But still, you know, again, we're talking systemic and all this other stuff today. And then in the non-BFR limb, what changes? We got a change in strength for what? Peak torque for the quad. And again, the single leg calf raise, we got a significant change as well in the non-BFR limb. All right. So these are proximal changes in strength, way distal changes in strength. Again, a very easy rehab model to follow 2 times a week for 6 weeks. Just get your cuff on 80% and able to show that these rehab exercises make pretty significant changes here. What are y'all's kind of parting thoughts on Eric's study?
Yeah, I think it's pretty good in the sense of let's just say like you have someone with a like an Achilles tendon repair or maybe an ankle fracture where you're limited in what you can do. Mm-hmm. We can get a carryover without directly targeting the plantar flexors or doing an ankle specific exercise.
Yeah.
Yeah. Well, yeah, I mean, I think it's also more to support the fact that, like we've all talked about multiple times, just the, potentially using an unaffected stimulus or unaffected limb for a big enough stimulus. And then we still have to have some stress that's consistent on the limb that we want an effect on, as opposed to just getting this pure cross transfer or carryover without having enough of a stimulus on that limb.
Right. All right. So let's put a bow on this. The most recent papers, non-clinical, but I think we can translate it over. If I got someone with a shoulder issue and I can get them to where they're doing cuff type exercises, if I can get 2 times a week for 8 weeks, it looks like I might get some pretty positive juice out of that. So just put the cuff on. Let's go 50% LOP. Maybe take your final set to failure, which is what we always say we want. But lots of times, the patients still have some juice left. We missed our load that we need to have. And like we put in that ACSM paper, the proximal muscles probably really need something that gets maximal muscle activation and gets them to failure. So that's for the shoulder. Then for the lower extremity, doing rehabby Jane Fonda exercises, your hip abduction and straight leg raise and all of that. Quad stronger, calf stronger, hip stronger, increased thigh, calf size, more ability to do more calf raises. So if I got a post-op person and they're just doing mat exercises, follow what we are doing, get the cuff on the involved limb if you can, and have them go through their protocol with that. Or if for some reason, like, someone I was just working with had a skin graft and it wasn't healed yet, so at his donor site, so we couldn't put the cuff on the involved limb, so we had it on the other limb. And then we did exercises on the uninvolved limb and then had him do his exercises with the involved limb afterwards until that skin graft healed up. And then we get the cuff onto the other side. Makes sense from y'all's standpoint? Yeah. Hey, yeah. I want to say too, it's crazy. Second one here, the cuff over the donor site graft, it's almost made the donor site graft completely go back to normal looking tissue. Crazy. Wow. Yeah. So I want to get with the plastics guys and, man, that's the real group to go after. Once you get in the plastic surgery world, you're making scars go away. Got some real action there. All right. So any final thoughts from y'all's side on this whole proximal thing, clinical pearls, what kind of studies you would want to see just to finish up here?
I think we need a backflow study. I think
NEARS.
Just establish that.
Yeah.
We definitely need that.
I think it could be very easy. And again, these backflow studies, you're going to, I would be very specific on what kind of system I'm using. Because again, we see if you pump these things up and do a few things, all of a sudden those will drift. They can't hold pressure, and you're probably allowing flow to go in. So you would need a system it holds pressure and maintains pressure the entire time, I think, to see the maximum backflow. Any other thoughts from you guys?
I think, in my opinion, we pretty well covered it there. It's, obviously targeting proximal is a real thing. And just, get a stimulus that targets those proximal muscles, whether you're applying the cuff to the involved or uninvolved limb.
Yep. All right. Well, the clinical stuff's coming. So we've got Alexander Franz's total hips work in Germany. It's ramping up. This rotator cuff trial looks like it's going to move forward. We got the SLAP trial down at Andrews, and Brad's going to be doing his MLB stuff. So hopefully we're going to start to see a lot more research to back up, I think, what we're all seeing clinically. Sound good, fellas?
Very good.
Yep. All right. Off to work and travel again. So thanks again for coming on. And just to remind everyone, if you like our podcast, go on and please subscribe to it and give us 5 stars. If you don't like it, just ignore it. Don't give us anything. And then next time we're going to interview another researcher, and this is kind of the way we're going to format it this year is have someone on as a guest, and then we'll get together as a group and break down more topics. All right, fellas?
Sounds good.
All right. I need more coffee. Peace.
Yep.
Same.
Thanks for listening to the Owens Recovery Science Podcast. Owens Recovery Science is a single source for PTs, OTs, ATCs, DCs, MDs, and other medical professionals seeking certification in personalized blood flow restriction rehabilitation training. Find them online at owensrecoveryscience.com.